another 2 minutes. Let other people join in. Okay, around 85 people have joined in. Am I audible clearly? Just a thumbs up would do. Okay, great. Thank you. Okay, I think we'll begin. Um, okay, okay. Okay, great. I think the recording has started. Great. I think we can begin then. The others can join in as and when they do. All right. I am not feeling uh, very great, so I have a very puffy face and everything. So I will not be putting on my video, but I hope uh, there's still some level of connect and communication that we can achieve, and it won't just be like a recorded, you know, listening to a recording, right? So, good evening, everyone, and I hope at least some of the concepts that we had learned the last time with regards to ontology and epistemology we remember. Okay, we do. That is great. We remember certain positions that are there. Yes, Shreya, you raised your hand. Do you want to comment? Okay, no problem, no problem. Okay, so just a quick, we'll just have a glance through it again. And no problem, sir. All right, just let me know if you can see the screen. Okay, I think you can. Okay, so let's just cover this idea of, so we went through all of this. We went through this idea of there are certain philosophical positions which differ in the way they see existence and the way that we can gain knowledge about existence, right? So, for example, if you are, we had done this exercise and it was very interesting to see your responses on this. I think we can do some kind of a content analysis by the end of this uh, not maybe this class, but maybe the end of this week, where we can try to figure out what are people's ideas about their own reality, and some kind of a thematic analysis we can do. We've got really nice responses, and I think it will be a fun exercise also to get to know the more qualitative side of things also. Okay, so we read about empiricism. According to empiricism and the schools that follow empiricism in a way, so we've heard about positivism, right? The idea is that reality is objective and observable, and it has to be apprehendable by uh, your senses or by your observations, right? Now, positivism in psychology, which is a more specific subset of empiricism, try to look at thoughts also as objective, right? So it also looked at this idea of, you know, capturing what is in the head, right? Being able to apprehend a true reality that somehow exists, right? But there was this very strong reaction towards it called anti-positivism, which said that no, reality is multiple, it is subjective, it is sometimes co-constructed also. We spoke about constructivism. Spoke about constructivism, where we are not only living in reality, we are also co-creating reality, right? So this is also a concept in theoretical physics. I'm not sure, like, if you are interested in it, but theoretical physics may there is this idea that when you look at an electron or when you look at a very small quark or particle, the fact that it's called the observer effect. The fact that you're looking at it changes its behavior. You know, it's almost like जैसे ही पेरेंट्स रूम में आते हैं तुम्हारा मन करता है पढ़ने का बट तुम नहीं करते तो जब when you are observed, right, your behavior changes. Lol, we are traffic. Yeah. So this idea of, like, okay, that's not really true, etc., all of those things. And then came this idea of post-positivism, right? Which was like, okay, there are certain things that can be apprehended, but not 100%. And that is where we are with right now, and with psychological sciences specifically. That, yeah, sure, we can try to gain insight into people's thoughts, but it will not be 100% accurate. And whatever we are doing is trying to reach the truth. We are getting closer and closer, and we'll always be getting closer because there is no objective truth as such. So post positivism has that scientific temper of sorts, right? This is important to consider now because when we talk about hypotheses, right, we will come to this idea of why can we not definitively prove anything. And that is why even our language around hypothesis is framed by this understanding of, like when we say, like, I think confusing रहा होगा काफी लोगों के लिए कि in the start के, like, we support or we have support for the alternative hypothesis and we fail to reject the null hypothesis. We'll get a bit into the depth of that by understanding the philosophy behind it. So I'm trying to help you, connect it in a very comprehensive way. So just like, stay with me, stay with me. Try to, क्या बोलते हैं? I will not, क्या बोलते हैं? Like, sorry, I'm so sorry. मतलब, it's almost like I'm trying to put a Subway Surfer reel besides the PPT. I think it's that difficult to capture attention these days. But I'm hoping that effort from your side can also help me and help you in turn, right? So if you understand it holistically, you don't have to rely so much on memory for consolidation of these facts, right? So yeah, we looked at constructivism, and then in the end, towards we are in some place called pragmatism, right? It's a paradigm of sorts, which is जहाँ से this whole idea of mixed methods research comes from, the best of both worlds. What is most pragmatic, right? Then we had spoken a bit about correlation and causation, and I think our time was up, but we'll speak about that. Okay, people have some kind of a basic idea about correlation. Constructivism is basically the idea that people are constructing are not just part of their reality, but they are constructing their own reality, right? So a lot of qualitative analysis का chosen paradigm is constructivism. So how do we construct our own reality? For example, if an empiricist tries to study pain, right? They will try to be like, okay, what is the galvanic skin response hota hai? Like, okay, do people sweat? How much are people sweating? How much are they, like moving around, etc. Or like, is there blood? We had gone a bit in detail about this in the previous class. So if you have by chance missed that class, I would recommend that you go ahead and watch that recording because we can't really get into like the full depth of it right now, right? So where was I? I think yeah, this is the thing. I tend to forget where I was. So yeah, so an empiricist would look at pain from a very objective lens. Say like okay, how can I know for sure what is the evidence for pain here, right? Are they looking at? Okay, they might look at an elevated heart rate or blood pressure spike, right? A logical positivist would also, I would say, infer this idea that okay, behaviorally दिख रहा है तो अंदर उतनी तकलीफ हो रही होगी. If a person is like rolling on the ground in pain, then obviously the logical positivist or the it's a combination of empiricism and rationalism, right? So they might look at it more in the sense of uh, it does not make sense right now to for a grown human being to lie down on the road and like just roll over in pain, right? So they infer that this idea that, and we use a lot of inductive and deductive reasoning in rationalism, right? So logical positivism combines both of these things, and so we infer that okay, this person must really be in pain, right? But a constructivist would look at pain in the sense of, for example, a constructivist would ask this question: okay, how does it feel when you are in pain? How does it feel? What is the sensation? For example, there are different ways in which pain happens. Like, people describe this kind of pain. एक स्टैबिंग वाला पेन होता है, एक इलेक्ट्रिसिटी फीलिंग वाला पेन होता है, एक क्रैम्पिंग वाला पेन होता है, एक बीइंग हॉलोड आउट वाला पेन होता है, एक पेन होता है विच इज लाइक यू फील वेरी सेंसिटिव बिकॉज ऑफ नर्व का सेंसिटिविटी, राइट? सो यू फील लाइक डोंट टच मी. So a very focused, yeah, a focus on a very subjective, a person's subjective idea of what pain is. Shooting pain है, definitely. Ants and like needles बोलते हैं ना, right? So constructivists would be more interested in that, right? So the interpreter, constructivism can handle this idea that the fact that you have never seen yourself, you've only seen an approximation of your image in a mirror, in photos, etc. Technically you have never seen yourself, and that is the best क्या बोलते हैं way to describe this philosophy behind constructivism. Okay, let's look at correlation and causation. I believe that most of you must have some kind of an idea with it, right? Let's use a little bit of our intuitive reasoning also, and our knowledge base थोड़ा सा. You don't have to be perfectly right, but let's see. Ice cream sales and murders. We've discussed this in your pre-question, right? There is a correlation between ice cream sales and murders. And and some of you had this question ke, when the question when one of the options was that tend to do this or leads to this, right? That is the difference. One of the major differences between correlation and causation. Correlation means co-occurrence. It does not mean covariation. What that means is that one thing will not necessarily lead to another. If you're making that kind of a claim, it has to be a causation study. It has to be an experimental study. If you are establishing any kind of, so this is called temporal precedence. A के बाद B आता है, B के बाद A आता है, ऐसा नहीं हो सकता, right? So ice cream sales and murders is a very strong correlational study. The more the ice cream sales increase, the more murders are also seen to be committed, right? Now we can't say ice cream sales uh, lead to murders, right? They don't. ये हमारा intuitive reasoning भी apply करते हैं हम जब we are trying to make this kind of an understanding, right? But studying an exam performance, there's a very strong correlation with that also, correct? But it's much more difficult to digest the fact that if I say कि it is still a correlational thing. Studying an exam performance के बीच में काफी सारे variables आ सकते हैं. Of course, there is a very strong correlation, but it also means that there are certain. You tell me, you have the best experience with studying an exam performance, right? Most in touch. What is your qualitative feeling around studying an exam performance ka relationship? Does it happen sometimes when you study but your exam performance is still low? Yeah. What are certain factors that contribute to this idea? Multiple factors. You are sick, paper correction was biased, questions बहुत difficult हुए तो silly mistake, something as simple as handwriting. Yeah, but what are the extraneous variables is what I'm asking. Overconfidence, sure. An inaccurate appraisal of whether you have actually covered the syllabus or not will also lead to very decreased exam performance. For example, you study only unit 1. You've studied technically, but that is not going to contribute to your exam performance. Lack of sleep, sleep deprivation, attention issues in exams, disturbance in exam hall, correct? एग्जाम हॉल में लाइट चला जाना, something as simple as that can also teachers gossiping. Okay, if they're gossiping around you, then that can influence. Again, an observer effect can happen. Temperature stuff, no fan and all. Correct. Skipping food, exam के time bar DJ बजना. Yes, yes, definitely. Distractions, etc. Right? There are multiple things that can come in between here. So, though it seems like a very strong causal relationship, it's not a causal relationship, really. Right? All of these are correlational, क्या बोलते हैं? Correlational relationships, right? But some of them, I want you to ask this question to yourself also. Hey, why do some of them feel more like हाँ ये causal relationship हो सकता है. Smoking and lung cancer को छोड़ के बाकी सारे correlational हैं. I'll tell you why effect of SSRIs on depressive symptoms भी correlational है. Or rather, the causal relationship is not that well explored. Because so there is this idea that serotonin के increase या decrease या imbalances की वजह से depression हो रहा है. But we have also seen that SSRIs have an effect on the hippocampus. It has also it also increases connectivity and it also enhances neurogenesis or like the re-enlivening of neurons, right? So does this on neurons and neuronal connections, right? So does this mean that it exactly the serotonin levels that are creating these kind of effects, or is it that these kind of effects are causing a person to have a better mood? Yeah, but such high. So a very good point Arima has said. Okay, such high correlation that we imply causation in practicality when it technically isn't a causation. Correct. The only way to be able to prove causation is by experimental studies, right? Experimental studies are the only method by which we can prove causation. And even causation or even experimental design has to be designed in such a way that other variables should not come in, right? Elimination of other variables is very important, right? So the first condition for causation to be established is temporal precedence, A then B, and not B then A. If the effects are causing the causes, then it is not a causal relationship, right? Covariation of cause and effect. If the cause changes, the effect also changes. For example, जहां जहां सुपरमैन जाता है वहां वहां डिस्ट्रक्शन होता है, right? Now this is a very observable fact that is said in the movies वगैरह also, right? कि जहां जहां सुपरमैन जाता है वहां वहां डिस्ट्रक्शन होता है, right? But is the opposite also true, right? Wherever there is destruction, is Superman there? No, right? Now this is part of philosophy, but you see कि Superman does cause destruction and it's not just a correlation. Then the third thing is elimination of alternative explanations. Control and scientific experimentation के through हम हासिल करते हैं ये चीज कि how do we maintain control that all the other extraneous variables do not come in, right? So for us to be able to prove that Superman does indeed cause destruction wherever he goes, we have to have one condition or one world where there is no Superman and see okay, whether there is destruction in it or not, right? Whereas correlation is a much more, so causation is very much more difficult to establish because there is an inverse relationship. We'll speak about this relationship later on. Okay, there's an inverse, how much you could try to control, and that much it becomes far away from reality as possible, right? Whereas correlation does not need a lot of control. Correlation is like, हाँ, there must be a relationship. Directionality है correlation में. There is a co-occurrence of two variables. अगर पॉजिटिव बोला जाता है तो दे इंक्रीज और डिक्रीज टुगेदर एंड अगर नेगेटिव बोला जाता है तो वन इंक्रीजेस एंड द अदर डिक्रीजेस एंड वाइस वर्सा लाइक अ गोवा प्लान लाइक फोर पीपल आर रेडी and their motivation increases, one person ka motivation decreases. A and B tend to happen together. There is no temporal precedence required. For example, यहाँ पर देखो shoe size and reading ability. These are both influenced by something extraneous or outside of them, which is age, right? Age के साथ साथ reading ability भी बढ़ती है and shoe size भी बढ़ता है. But just because you've enhanced your reading ability does not mean that your shoe size will increase, right? And just because your shoe size has increased does not mean that directly is causing your reading ability to increase. Correlation has also a tolerance for other co-occurrences. यानी extraneous variables भी अगर affect करे उतना तो उतना फर्क नहीं पड़ता है, right? Now this is the starting of the next bit of this class, right? Okay, we have learned a bit about the philosophical foundations of why we do research the way that we do research, right? We observe, we question, we hypothesize, we predict, we experiment. The results either relate to some kind of theory or, they find that, okay, the hypothesis was not supported. And then we go back again to questioning and hypothesis, right? So let's move on. Second part. Are people with me so far? Okay. I am a university teacher, so I think I have that, क्या बोलते हैं, very academic energy vibe. Uh, I get that that is not so, क्या बोलते हैं, attention grabbing. But like I said, please help me out, right? So what we'll cover today is what is a research problem, what are variables, what is an operational definition, what is a hypothesis, right? Uh, Most of these things we have come across in your TY and your MA also. Anybody who is outside of this, if you don't fully understand, that is completely okay. I have tried to boil it down to the very basics. Tried to dial it down to the very basics. So I hope this can be a good base for you to move on to. But I think if most of you are trying to attempt the net, most of you must be in your BA and masters. This is deductive reasoning. Okay. So this is basically what we had covered. Ontology is how we view existence or reality. Epistemology is how can we gain knowledge about it and how can we gain accurate knowledge about it. And methodology covers the methods by which we gain this knowledge. In essence, your ontology or your belief about reality influences your epistemology, your belief about knowledge, which in turn guides your methodology, how you will investigate, right? We'll cover that. ऐसे इसको है ना थोड़ा I would say कि keep it in the back of your head, right? I had posed this question in the earlier class. Certain kinds of therapy modules that you like, etc. Try to trace back your idea of what human mind is, how it works, what is behavior, what is cognition, thought, feeling, etc. Right? And you will find that there is some kind of an ontology or how you view humanity or human psychology, right? Which prompts you into going into this direction, right? अगर आपको न्यूरोलॉजिकल इन्वेस्टिगेशन ज्यादा पसंद है तो यू आर मोर लाइकली टू थिंक ऑफ थॉट्स एंड फीलिंग्स एज connections and as a function of the structure of your brain, right? You're more likely to think about it neurologically because you're thinking okay, thoughts and feelings are somewhere physiologically based, right? Whereas if you are more, I would say, if you prefer a more qualitative inquiry, you might have this view of a constructivist at heart, who is open to this idea that people around us influence us, and you know reality is actually really subjective, based on, and very changeable based on how who we are interacting with, right? Our reality. Okay, let's look at this. If you imagine a house, the research problem is the land, which is a general area of study, right? We'll come to a very specific example in the next slide, but the research problem is the land. The research question is much more specific. It's the walls, it's the ceiling, it's the foundational structure of the home. The variables can be understood as the brick, the things that you create the walls vagera with. So you need variables to be able to form a research question and to actually translate a research problem to a research question, right? The research design, or how you place those variables, is kind of like the blueprint. And the hypothesis is your imagination of what the house will look like afterwards, a concept image, right? With me so far? Okay. It's a broad area of concern, research problem. For example, if you have this question, what causes depression, right? Tell me, according to some of the literature you may have read. Okay, so childhood trauma can be a contributing factor to depression. So isolation, lack of social life, loneliness, cognitive distortions, life events, genetics, hormonal imbalances, serotonin deficit, environment. Environment is very vague. Like, how is the environment contributing to depression? I understand, like, I am guessing about what you mean by environment, like, a positive or a negative environment. But yeah, low self-esteem, traumatic life events, internal incongruence. I'll just take a screenshot of this because it's very interesting. I think you should also make a note of the responses that all of you have made, and try to find out the ontological position that you're taking here, right? That is, how are you actually viewing reality in terms of very physically observable terms, or, very psychological, very, post-positivist. I mean, there is this idea that we are, constructing some of it, and not all of it is accessible to us. Procrastination, temperament, unsupportive environment and genes both, sure, right? Multiple factors. And depending on your persuasion and your field of study, you will try to study and you will try to create research questions based on what you see or what you read, right? So if all of you were to, now let's do this exercise. Remember your first response, and based on that response, try to form a research question. It can be specific, it can be very exploratory also. Try to form a research question based on this. A research question is basically a very specific pointed question which can have an answer if we research it. For example, if someone said serotonin deficit, right? The research question would be, does a lower than average level of serotonin in the body result in depressive symptoms, right? Now, very observable, right? We can try to, maybe by imaging, or maybe by, blood level ka analysis, we can try to gauge serotonin levels, right? And then we can have this kind of an idea of, and we can have some kind of a behavioral rating of depressive symptoms. Can genes have an impact on depression rates? Um okay, again, that is I would say that is still a very broad research problem, right? How can we, the point which, if you remember here, when I said research question is the wall and variables are the bricks, you have to be very concrete with the research question. Does depression have a genetic basis? इसको आंसर कैसे करेंगे? How will you be able to find this out? Does low self-esteem affect low mood? Yes, very measurable. How can you measure low self-esteem? Using a questionnaire, most likely. And how can you measure low mood? Again, mostly questionnaires are used. Does a lack of social life result in depressive symptoms? Now, when you say result in, right, you are trying to imply a causal relationship. Even affect has a causal relationship, but lack of social life is very difficult to put in experiment. Yeah. Questionnaires ka reliability, where what it also depends on, what you mean by when you say reliable. Does early experience of abuse and neglect increase the likelihood of presence of depression in adulthood? Very appropriate, very measurable. I can measure, okay, has this person had some kind of an experience of abuse and neglect? And I can ask this question to 100 participants and I can have their scores and the likelihood of presence of depression in adulthood. Now I can look at depression from a questionnaire point of view, or I can look at depression from a diagnostic criteria, right? I can compare two people. So especially if I want to establish a causal relationship, I will take two groups, one who don't have depression or a diagnosis of depression, and second, a group that has a diagnosis of depression, right? Very well. Many of you have brought forward really important ways of asking a question about what causes depression, right? Maternal neglect के बारे में बात की है किसी ने, बोलबी के फैन लग रहे हैं. Yeah, mixed methods can be used. Sure. So it can be as complex as possible. It can be as simple as possible also. But the first step is always literature review. What does the literature say? The research question is a measurable and concise question. Some examples are: is depression related to maladaptive ways of thinking about success and failure? How can this be measured? We can have some kind of a questionnaire about maladaptive ways of success and failure, or we can study this qualitatively. How do you see success? How do you see failure? Impact do you think success has on you? How does success an incongruence within the self? This view is much more likely. Hello, is it better now? Okay, great. Is depression related to serotonin deficiency? Right? It all hinges on the fact that can we measure the levels of serotonin in the head accurately? Is depression genetic? How can we answer this question? We only know about genes by their expression, right? So if there is a strong history, ट्विन स्टडीज से पता चल सकता है, फैमिली स्टडीज से पता चल सकता है, tracing out lineage and finding out the kind of the occurrences of mental disorders in the family can have a very strong can give a very strong idea of is depression genetic. Is social isolation a contributing factor to depression among youth? Much more pointed research question, right? Does exposure to discrimination make one more vulnerable to depressive symptoms? Right? So these are research questions, but how have we come from what causes depression, such a broad category, say, to something so specific, right? And what do we mean when we say measurable and concise? Can diathesis stress? Diathesis stress is a proven model of is a proven hypothesis actually. ये proven hypothesis नहीं बोलते, but like it's a very well supported hypothesis. That does play a role in depression. Diathesis stress model. There is a vulnerability and then there is added stress. Now let's look at variables. If you think of volume as a variable is anything that can vary, right? Anything that can be low, high, and be also like, based on certain, so either it is continuous variable or it is discrete variable. Discrete variables are usually things like, for example, gender or biological sex rather. Male, female, discrete है, intersex, discrete है, right? If you say number of people, you can never have 1.5 people. It is discrete. It is not continuous in any way. But volume is very naturally it's thinking. It's a very continuous variable. कि वो increase decrease किया जा सकता है on a very smooth. I would say the quality of the variable is smoothness. जिसके बेसिस पे वो कंटिन्यूअस है या डिस्क्रीट है पता चलता है, राइट? Smoothness between the categories. So, for example, I can take age as a category, right, or as a factor. When I call it a variable, I am saying that there are differences in this value for people in the population, right? There are people who are very young, there are people who are very old. Now, when I categorize it this way, I'm making a discrete categorization of the variable. I'm saying कि 25 से नीचे वाले लोग young है and 25 से ऊपर वाले लोग, I'm so sorry, old है, right? But if I say age in terms of months or days that you have lived, now that is a more continuous variable, right? So whenever you think about variable, think about the volume button or sorry, the volume dial, right? जो 1 से लेकर 10 तक जा सकता है या लाइक व्हाटएवर 0 से लेकर 100 तक जा सकता है, राइट? बट इन सम केसेस जैसे वो फैन का रेगुलेटर जब खराब हो जाता है तो दो देर आर लाइक 0 to 5 वाला सेटिंग्स और 1 to 5 वाला सेटिंग्स, वन इज लाइक द स्लोएस्ट ऑफ ऑल, इट्स लाइक डेथ, एंड 5 इज लाइक so fast that it's almost a hurricane, right? Operationalization के ऊपर जाते हैं, AKA make it make sense. Operationalization is what converts the research problem to a research question, right? So let's have this exercise. When we call someone rich, when we call someone rich, that's a very subjective concept. AKA is also known as. When we call someone rich, we are what is rich according to me and what is rich according to you may differ greatly, right? For example, in Mumbai, a good salary and in a remote town or city of India, a good salary का concept बहुत vastly different हो सकता है, right? But richness के indicators क्या है? First is income and second is assets. What do you have, right? Now to convert this indicator into variables, we will try to measure what? How can we measure richness, right? We can measure it by noting down the income per year or by the number of assets, the total value of all the houses, cars, investments that you have, right? Similarly, academically high performing अगर बोलो, तो उसके इंडिकेटर्स क्या होते हैं स्नॉबिशनेस के को छोड़ के? एवरेज मार्क्स ऑब्टेन्ड इन एक्सटर्नल एग्जाम्स. इफ यू टेक यूनिवर्सिटी ऑफ मुंबई का rubric or like pattern, I don't know why you would, but we do. Average marks obtained in external exams and average marks obtained in internal exams. Because I think we also have this understanding that there can be a discrepancy between the two, right? So we can have academically high performing people in, okay, through their 2 years of uh, their MA, how much did they score or what is the average score that they got, right? So we can rely on the percentage of marks for that. We can rely on the GPA for that, right? So how have we converted something which is a concept or which is some kind of an idea of what we want to measure into something that can be concretely measured? It's called creating a working definition, right? Similarly, aggressive tendency है किसी ने भी बोलना है अगर, right? उसके indicators क्या है? Aggressive behavior है, verbal aggression and trait aggressiveness. Trait aggressiveness matlab the propensity to get aggressive or feel aggression, I would say, right? If you want to study aggressive behavior, then the variable would be, for example, if it is a study of children in school, number of times a child fights with their peers during recess, in a week, in a month, how many times does a child fight, right? And we get a lot of ऐसे sample का data लेते हैं, and then we figure out कि okay, certain children are higher in aggressive behavior. That is when we can say, right? Similarly, verbal aggression के लिए we can use score on verbal aggression का कोई inventory by the spouse, right? Inventory means a questionnaire basically for the purposes of this class. And if we say that we are trying to measure aggressive tendency by the indicator of trait aggressiveness, we will most likely try to get a score on a personality measure. So if you score higher on that, that means you have more of aggressiveness ka tendency. And if you score lower on that, you have a lower tendency to get aggressive. Okay. Similarly, we do this for other indicators as well, for other concepts as well. When you say working memory capacity, we have a look at performance on complex span tasks, attention span tasks, and holding multiple bits of information in working memory, right? The variable or the way that we can operationalize it is by having some kind of a digit span code. Digit span is a task that you have to do. Okay, how many digits can you remember, right? And accurately. Holding multiple bits of information, number of words accurately repeated in sequence. That can be a good measure of your working memory capacity, right? This is a good measure of this. So this whole process is called operationalization, right? Similarly, when we say task performance, in certain kinds of tasks, accuracy is important. So the number of correct and incorrect responses, for example, your exams are task performance, I would say accuracy and speed both matter. Being able to complete the exam is also a very important criteria. But the marks that you get, number of correct and incorrect responses, is the way that you are measuring task performance. If you are taking speed, then time taken to respond, or what we famously call response time, right, is indicative of task performance. So we call good task performance or high task performance or low task performance based on what kind of a score you get here, right? Similarly, performance rating by supervisor. Rating on a rubric है अगर, for example, if I say के, okay, you were present for a lot of days. If I'm your supervisor, you were present for a lot of days, उसके लिए 2 points. You were cooperative most of the time, 2 points. So if there's some kind of a rubric, then this is quantitative. But if it is just a measurement by the, or it is just an evaluation by the supervisor. Say okay, this student feels committed, consistent in their uh, completion of tasks, etc. Now that is a more qualitative measurement of task performance, right? Similarly, pain, self report भी कर सकते हैं. There are behavioral symptoms of pain that can be measured, and there are physiological responses to pain that can be measured, right? Heart rate changes, blood pressure spikes, pain matrix lighting up. So pain matrix is this idea that these multiple parts that are involved in interpreting pain, right? And it does not look like certain parts as such, like ऐसे कोई जगह नहीं है, but it's like the whole connection lights up. Yeah. And then, okay, I hope people have understood operationalization. I will give you some exercises so that you can, because this requires a lot of practice. It's a very conceptual understanding that grows over time, right? A hypothesis is a tentative answer to the research question. So we have posed these questions here, right? Is depression genetic? Is depression related to serotonin deficiency? Is is social isolation a contributing factor to depression among youth? Right? So, sorry about that. Yeah. So if I have to answer this question, I would say yes. For example, if I have to say, is social isolation a contributing factor to depression among youth? The hypothesis would most likely be based on research and based on literature review. I would say that yes, social isolation has a negative effect on or a negative relationship with with occurrences of depressive symptoms among youth, right? The hypothesis in this way is a tentative answer to the research question. Now what I want you to do is, we'll do one together, but I want you to do the rest of the two by yourself, right? I want you to convert this idea or this idiom, right? This is a proverb that is said usually, right? I want you to convert this into a research question or a hypothesis that can be tested, right? Spare the rod and spoil the child is usually said to indicate what? Yeah, technically the idea is child abuse. Yes. If you don't hit your child, they will get spoiled, right? So the hypothesis here would be what? If you would want to translate this into something that can be tested. Okay, does this really happen? If you don't physically abuse the child, they would not be docile. That is exactly what the idiom is saying. Tell me, if I were to test this, right? If I were to actually test this, parents who use physical abuse to train their child get better results in terms of discipline. Hmm, okay, very good start here. But I would say again, in terms of discipline वगैरह थोड़ा vague हो जाता है, right? When you have a research question or a hypothesis, you kind of have to be very concise. Parents who use physical abuse to train their child report fewer occurrences of aggressive tendencies in children or in their child. Report less maladaptive behavior. Perfect. There is a significant relationship between child's behavior and punishment. okay, but that's okay. That is a relationship that is there, but it's not the exact relationship that is being talked about here. It's saying that punishment uh, or physical, physically punitive or physical punishment can help in creating more docile children or less or more agreeable children, right? So what this person said, parents who use physical abuse to train their child get better results in terms of discipline is the correct hypothesis that you would form here, right? And then again, we know from a lot of psychological studies and our literature review that physical punishment, sure, may result in, this is just so that we have a good understanding. Physical punishment, though it may create more docile children, it does also create a lot of esteem issues, self-concept issues, all of those things, right? So, अगर वो variables of interest है नहीं, तो sure, spare the rod, spoil the child, right? So, a good hypothesis is parental use of physical punishment is related to less or more agreeable behavior in children in adolescence, right? Now, what I want you to do in your own time is make the same kind of hypothesis for the second one and the third one. Okay. Now, I'll just quickly cover this. We have known null hypothesis and alternative hypothesis for a long time. The null hypothesis basically says कि variables में जो हम study कर रहे हैं, the variables under investigation are not related in the population, right? But the alternative hypothesis claims some kind of an opposite to that, right? If there is a relationship between the two variables in the population. Now, the relationship can be directional or non-directional. If this has a positive relationship, or this has a positive effect, or this increases the occurrence of this other thing, or this decreases the occurrence of other things, or this just has an effect. So, when we say non-directional, we are just saying that there is an effect, but we don't know in what direction. We don't know if this variable ka increase or decrease will cause an increase or decrease in this way, in this other variable. Why do we say, so when it comes to the null hypothesis and the alternative hypothesis, we always use this kind of language. Okay, we support or we have found support for the alternative hypothesis. We are never able to prove, right? Now, this comes again from this idea of post-positivism. We can never prove something to be true if we are only taking the sample and not the population, right? And that there is significant. So, when do we reject the null hypothesis? And in statistical analysis, also, the main aim is to reject the null and not to confirm the alternative hypothesis, right? We are not trying to prove that there is a relationship. We are trying to actually prove that there is not a relationship. I know it's a bit convoluted that way, but this is the reasoning behind this idea of we fail to reject the null. We don't accept the null. We don't say that the variables under investigation are not related in the population for sure, right? Just because we haven't found evidence for the alternative hypothesis does not mean that the null hypothesis is true. And just because the null hypothesis wasn't true, or like, we didn't find evidence for the null hypothesis, the alternative hypothesis is true, right? So what we only have from data is support for either of the relationships that we are trying to propose. This is it. Thank you so much. We are on time today. Are there any questions? Okay, I think your next instructor will be joining in soon. I would encourage certain questions, but I would also say that definitely try to attempt these hypotheses. creating, right? So that you can have a better grasp on, hi, your next instructor is here. Thank you, everyone. Take care. All the best, Rutuja.
Yeah, thank you. Thank you, Aisha ma'am. So, fun fact, Aisha ma'am was my professor. Hi guys, I hope I'm audible. Can you guys just give me a confirmation about that? Okay, great. Hi, so my name is Rutuja, and I'll just give you like a brief introduction. I have been teaching psychology at a PG level in Bhavan's College, which is in Mumbai, since 3 years now. Apart from that, I practice as a psychotherapist. I am also a researcher in the DEI field, which is diversity, inclusion, diversity, equity, and inclusion in the corporate world. So that's what I do majorly when I'm not having an existential crisis or not looking at brain rot memes on Instagram. All right. So let's go ahead with today's lecture. So as you all know that I'll be teaching abnormal psychology. So I will just um, share my screen. Yeah, can you guys look at the presentation? Is my presentation visible? Okay. 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 So before we go ahead with, like learning about the different disorders, right? I want you guys to have like, like most of the teachers or, even the way we study, even the way the books or the research papers that are written about abnormal psychology or clinical psychology, right? They have a very um like a unidimensional way to look at behaviors or like the disorders basically, right? So I would like to propose like a different way to look at, like just because it's clinical, we don't have to take a clinical approach towards it because we're dealing with human beings, right? So we're going to look at like psychopathology from a critical, like critical lens. So what is abnormal behavior? Like if you guys can, like quickly just type in basically like what does abnormal behavior mean? Whatever you know till now. Okay. Not according to the norm, yes. Deviance, yes, yes. Correct, correct. Okay. So, yeah, maladaptive, exactly. And I think you might also know what is a disorder. Like everyone feels sad, right? Like at some point in our life, right? Like each one of us will feel sad or very happy or very excited. Does that mean that all of us have, like, that is that called a depressive episode or a manic episode? No, right? Like it becomes a disorder when it is like the intensity of the emotions or the thoughts or behaviors goes on a very high level, and like the functioning, our everyday functioning, when it starts affecting our relationships, when it starts affecting our daily functioning, when it starts affecting our work, our academics, right? That is when we consider, okay, this is a disorder now. This is something like we need to provide care to this person, right? Yes, the 4Ds, correct. So it is also like, when does it become a disorder? Like for some time, like let's say some genuinely, let's say you like went through a breakup. Of course, like usually you will be sad, right? That's a normal response to it. But like if it gets, if it affects you on a whole different level for a really long time, then it could lead to different situations. It could lead to a depressive episode, it could lead to mania, or different. It depends. There are like different experiences of people, right? So time is also something which is very important when we look at like disorders or abnormal behavior, right? So there is like okay. So, when we think about, or when we look at like, clinical psychology or abnormal psychology, I hope everyone, has at least little bit of, I know there are some UG students as well, but, I hope like, or if you don't, you should read up on like, the way we decide like what is a disorder, right? Like when we think about abnormal psychology, clinical psychology, we think about the DSM, ICD, right? And DSM is something which is considered like the Bible of in the clinical world. But the way it is a very sociopolitical like document, and we cannot directly maybe, or the way the process of uh, deciding what is a disorder, or which behaviors to be called or grouped together as a disorder, right? So these are quite problematic, and in the recent times especially, because there has been a shift in like the way we look at mental illnesses, the way we look at sanity, right? So a lot of this like yeah. So okay, thank you, Kushi. Yes, so a lot of behaviors. So a lot of like professionals as well as like activists, or like social reformers, right? In the recent times have talked about like, is this the way people like. Okay, one important book that you all should, despite like whatever specialization you are planning to or you have done, like I think one important, like because you are uh, a psychology student especially, I will share the book in the group. It's Mark Fisher's Capitalism Realism, right? So that's one important book, right? So one of the discourses that is there with regards to how we perceive mental disorders is like, is this a normal reaction to a horrible society that we live in, or is this something wrong with me, right? Like when we put like an individualized lens, right? Like we are living in a capitalist society, right? We are we are like, when I say, okay, oh, this is who I am also a product of the society that I live in, right? I will share the book. So it's so a lot of one discourse, like there's this major discourse which is like, okay, when we say this person is going, let's say I lose my job, okay, and I have to feed my family, and I do not have generational wealth or like saved up money, and then of course what will be the natural reaction? That I will become very tensed. There will be a lot of like anxiety, because I have to put food on the table, I have to send my kids to school, I don't have like money, I don't have a job right now, right? The job market is horrible, so there will be anxiety, there will be depression, right? So of course, like when, because also of how popular pop psychology has been, especially on Instagram, like a lot of self-care things, like you cannot suggest like self-care or journaling to a person who has lost their jobs, right? So it's like when we look at disorders, right? Like a lot of this is the discourse basically, okay, is it a disorder? Is there something wrong with the person, or is it just a reaction to the reality or the society or the circumstances, right? So that is something that you guys should also reflect upon. And another thing that we need to look at, Yeah. So, to look at like disorders, I would also like to explain, there are different ways in which we look at disabilities. I hope everyone is aware that, mental disorders, neurodevelopmental disorders, and neurocognitive disorders are recognized by the government of India as disabilities, right? So it's important to understand the different ways in which literature perceives, or like human society perceives, disability. So the three major ones I would like to talk about is, first is the medical model. This is what we generally follow, or we are taught to follow in clinical or abnormal psychology, right? Where we look at the problem, we look at like what is wrong with this person. We need to cure something. We are not looking at the person as an individual. We are looking at like the problem, the issue. So it's a very clinical, very medical approach. Then it was criticized, and then came the social model, where we are looking at like, the person is not like, the disability is because of the society, right? Like the society is made in such a way where if there is something, some issues that a person is facing, because it is the failure of the society to accommodate that person into our society, so that, like the blocks are there in the society and nothing is wrong with the person, right? Like the world should be, like everyone has a right, like has a right to live in this world, right? And we have technology for the most ridiculous things or the most harmful things, but then, our technology has not advanced, or not just technology, but the way we function in the world, or like workplaces, is not adaptable, or not like the accommodations are not considered, right? So the social model of disability does not look at the person, or like does not think that there's something wrong with the person, but something wrong with the society, right? Like for example, very very simple example, like let's say someone has let's say someone is autistic, okay, and they go to a corporate or 9 to 5 corporate job, right? Just being like, and what is the office, usually what is the office setting like? Very bright light, a lot of people around, a lot of noise, right? So these things will cause like, like sensory overload, right? So you'll be like, oh, this person, if you look at it from a medical model, you'll be like, oh, something is wrong, like we need to cure autism, we need to, like this person needs to do something. But like from a social model perspective, we'll see, okay, it is the way the office is designed. Maybe we can have a quiet room where, like very few people are there, or we can provide, like disability aids, like there are headphones or earphones which are there, which blocks noises, right? Or and we can have dim lights in those areas. We can have like a work from home model, things like that, right? So and then lastly we have the diversity model, where it's like, disability is not looked at as something special, right? Like in India we have like special school, special needs school, right? So we don't look at disability as something special, or something, like, or something that we need to pay a lot of attention. It just that doesn't mean we do not provide accommodation, care, and compassion. It's just that the way some people have blue, like some people have black hair, some people might have white, blue, red hair. Similarly, it's another way of being human. So it's looking at like diversity, right? So these are the. Oh, oh, my bad, my bad. Okay, it was just this. It was just this. Like it's just written this. Yeah. Yeah, thank you for that. Yes. So, yeah, these are, like you should be aware about the way we look at disability, right? Which also means like the way we look at like disorders, and the way majorly, right? In most colleges and the books that we refer to, the research papers, the way we are taught how to give therapy, we look at disorders from the medical model, right? And we need to move more towards the social and diversity model. I'm not saying, like we don't look at like, just because we're looking at people from social or diversity model, that doesn't mean that, we do not care about their treatment, or, like care or compassion, right? It's just the way we are looking at people, that is looking at them as an individual, and not just, what is wrong with them, or like what needs to be fixed, or what needs to be cured, right? So, and one way to do this is, uh, having a phenomenological approach, right? So what is okay. I will read the comments later. Like you can message in the like you can message, but I'll read it later. So it's like I'll need like a lot more time to talk about phenomenology, but just to give like a brief introduction, we cannot do like a more detailed dive into this, but to give like a very brief introduction to it, phenomenology is basically, it was a philosophical movement during, as you can read on the slide, 20th century, right? It focuses on subjective experiences, right? So what is, why subjective experiences, and how is it relevant here, right? Like so there are a lot of like okay, so like you can have, let's say you can have 10 different people who have schizophrenia, right? But the way it looks, right, like the way it manifests in each person will be very just one second. Oh, okay, one second, I'll just, is it visible now? Like now I have changed to share screen. Okay, great, great. Yeah. Yeah, so sorry about that. But it's okay. It's just like this written information. So basically, like, why is it relevant? Yeah, I was talking about schizophrenia, right? You can have like 10 different people who have schizophrenia, but the way each person manifests the symptoms, right? Like, you've learned about combinations and permutations, right? There are different symptoms. The way they manifest for each person will be very different, right? That plus, as well as till now, majority, if not all, majority, yeah, I have not switched to the slides one. I'm just talking. I will switch to the slides when I need to. But yeah, thank you for letting me know. So yeah. So another reason why we need to focus on like why phenomenological approach, like subjective understanding, when we look at the research, when we look at the way the treatment plans have been, made, when we look at the literature of abnormal psychology or clinical psychology, you'll see that, very less perspectives of people who have gone through these things have been taken into consideration. Even when the DSM is made, right? Now they have, hopefully maybe they are taking considerations, but till now they hardly, um let's say, it's just professionals. Yes, it's like very valid licensed professionals who are, talking and making the checklist of symptoms, but the real experiences of people are not taken into consideration. Like for example, one example, yeah, it was an outsider's view, correct. Like for example, when we think about, like, we have gender dysphoria, right? Like when a person, like, I hope everyone is aware about gender dysphoria. If there's anything where you need me to like explain, you can just write in the text. So clinically, like, let's say a trans person comes to me, and then like I will do like go with my checklist of gender dysphoria, their childhood experiences, and like but if we take a phenomenological approach, I will also ask, like, if you are aware, like, in the LGBTQ community, something that a lot of trans people do talk, it's like gender euphoria, right? Which is not considered in DSM, or like in clinical studies. We don't learn about that, right? So like, okay, gender dysphoria, this person is, like, we diagnose them, they have gender dysphoria, but then again we are looking at it just like, okay, what is the concern only, right? We're looking at it from a very medical model perspective. We need to look at the entire individual, because the person is so much more than what is just wrong with them, right? All the other, and there's also a spillover effect of our experiences, or like the symptoms in other parts of your life, right? And it's all very much connected. So looking at it, like, if we take a phenomenological approach, we would also ask them about, like, okay, what are the things, like, like, there's this term gender euphoria, which is like, some people, when they wear, let's say, wearing feminine clothes, or like, like sari or wearing a sari would make me feel happy, or when I put my, let's say, do my eyeliner, right, I it makes me feel really nice. It makes me feel more confident about the way I like that is my that is my definition of being a woman, right? Like, and again, that is again very subjective experiences, right? So that is a phenomenological approach. There's much more like a very deep discussion on how to take a phenomenological approach in the clinical practice, but for now this is a good base understanding for it. I've switched my slide, I hope it is visible, right? Also, why phenomenological approach is important. I think most of you might have seen this video on Instagram where this person, she's saying ke he suffers from autism, and then the kid is like, I don't suffer, I just have it, right? So again, that's a different like a phenomenological approach where subjectively experience. Now this doesn't mean ke a person, so it can be like a like the way we look at something, like symptom, problem, just have it, a superpower. Like for example, ADHD, a lot of people do look at ADHD as these are the problems, that this is the dysfunctioning that is happening. I'm not able to do certain things because of my ADHD. And that is, there's nothing wrong entirely, right? And plus we're also giving the person the power to perceive or talk about their experiences, right? Plus it's like, oh, I have ADHD, but I'm able to manage it, and there's just something that is there, and because of it I may behave differently than your usual neurotypical, or people might perceive me as weird, or things like that. Versus there are some people who who feel like their ADHD is their superpower, right? Some of the experiences of ADHD can be perceived as superpowers for some people, where like for example, working under pressure, or like working during chaotic situations, right? So ADHD one disorder, but it can be experienced in three different ways. It can be manifested in three different ways. Plus it can, same person, sometimes it can be just a problem, and some other times it can be a superpower, right? So that is why, like, phenomenological approach, we are honoring the person, we are honoring their experiences, and we're not just relying on people who have like, not like DSM. When I say people, it's like creators of DSM, or researchers who do not have the experiences, we like and they are just from an, as Arima mentioned, from an outsider's perspective, we are just saying, okay, what is, I don't have it, but from what it looks like for my clients, and this is what my understanding of it, and again, that can be very biased, right? So yeah, one way to on a personal level, how can you, as a student, as even later when you become a therapist or a psychologist, like, there are different communities, there are different ways, like online, right? Like for example, there's on X, Twitter, at hashtag actually autistic, right, where people who are autistic talk about their experiences. So like that, you can go, you can find these communities not just on Twitter, maybe Instagram, Reddit always has like a lot of different communities, and you can really understand from the person's experiences of how having certain disorders, how is it for them, because when you go for the people who might have um, gone for their semester 3 clinical psychology internships, they might have realized, okay, what we learned in class and when we go on field, there's a very huge difference. It becomes quite difficult, like to identify, okay, okay, what is happening, what disorder am I looking at, right? So that's why, like, like, going through these communities, or actually learning from the people who do experience it, might give you a better understanding and a better perspective of the disorder. Okay. Any doubts till now, guys? Okay, I will take that as a no. Just a list of, like, how some of the prominent factors that affect the way symptoms might manifest differently, right? That's why we cannot just look at like the ICD or DSM and be like, okay, this is how it is supposed to look like. uh, like one quick short example. For example, there is depression. Okay, what are the symptoms of depression? Can you guys quickly tell me what are the major symptoms of depression that we look at while diagnosing? Correct, correct. Yes, yes. So, uh, let's take two people. One person is a college going student, upper middle class family. Okay, so does not need to earn money, right? Maybe for whatever, so something happened and that has triggered a depressive episode, right? And there's another person, same. Let's say this person is 19 and the other person, let's say first person's name I will, let's say Raj, and the second person is, let's say, Rohit. Okay, so Raj is a college going upper middle class, coming from an upper middle class family, college going student experiencing a depressive disorder, goes to the psychiatrist or psychologist, not able to sleep, difficulty in sleeping, not feeling hungry, not feeling motivated, not going to college, missing colleges, staying in bed, right? All of those things, and then they're like, okay, this person has depression. Versus Rohit also 19, but Rohit is a daily wage worker. Rohit is working working on construction site. Okay. Now, Rohit might feel like sadness, intense sadness, right? Might have like depressed mood, but he has to, as I said, daily wage worker. Even if he might have problems in sleeping after doing like hard labor for 12 hours, 14 hours throughout the day, his body will get tired, his body will fall asleep, right? Will need sleep, will need food. He might not feel like eating, but he will need food, he needs energy to do all the construction work, right? So a lot of, and like he might feel like, okay, I don't want to go and do my work, I don't want to do those things, but does he have a choice? No, he does not, right? So these social economic differences also play a factor, right? But if this person goes to, if somehow, let's say there's some camp or whatever, will this person even get a diagnosis for depression? Hardly, no, right? So when the diagnosis is not happening, then the treatment will also not happen, right? Again, the treatment will also on a ideally the treatment will also you know um include him having like proper minimum wage, right? Because that could be a leading factor for him having depression, right? But I'm just saying कि, you know the way a a disorder might show up in different people can be very different, but that doesn't mean कि, we just have to look at the textbook classical image of the disorder. I hope that example was clear. This is okay. Now, these are the questions that I would like you guys to reflect upon, like, whenever you get time. These are like very huge discussions, right? One, who decides like what is or isn't a disorder? This is very, very important because, like, for example, one of the most, popular like things, like for example, a lot of years ago the DSM did consider homosexuality as a disease, and then when they needed homosexuality for for political benefits, they declared it to not be a disorder or not a disease, right? Similarly, in the recent the revised DSM, we will be pathologizing grief. Like there's a timeline. Oh, if you're not, let's say you god forbid, like you lose a loved one, and then if you are not back to back at your job within 6 months, then okay, there's something wrong with you. You have like this grief disorder, right? So again, like are we who is deciding to on what basis, right? Very capitalistic basis majorly, right? So I want you guys to like read up on the history and the way DSM is made, right? And the history of how mental disorders, a lot of mental disorders have racial history, um, misogynist histories as well. So That. And secondly, just do a thought exercise. If we did not live in a capitalist society, if all our basic needs were met, what would be the mental health conditions be like? So there's this whole discourse in in the recent years that if we did not have a capitalist society, so some of like the communists, they do believe that all the disorders would go away. I do not really agree with that, but a lot of it will decrease. A lot of it, yes, yes, yes. A lot of like we will still have some systems of oppression. We will have like abuse in family. There are other systems of, or like not just capitalism, but let's say different systems of oppression were not there, right? Then what would mental health conditions, mental health, as a society would look like, right? So I want you to think, because like even if let's say family abuse also, right? Not invalidating or justifying any abusive behaviors, but like a father who is working, like, or a mother who is working, and especially now when mothers like who go out and work, all mothers are working mothers, but the ones who go out for like let's say a corporate job, right? Like facing a lot of issues and coming home, and also like managing the house, and might displace or might neglect the child. Now that is like abuse, but then intentionally, unintentionally, that becomes abuse. Now let's say they did not have to work so hard, or we had like proper wages and everything, then that possibility of abuse goes away, right? So that is where I want you guys, like that is the kind of thinking exercise I want you guys to do. Okay. So I hope any doubts, guys? I'll just quickly look at what all you guys have written here. Okay. Okay. All right. So today, I hope there are no doubts. If there are, then or if you have any opposing opinions, then we are open to that as well. Just be respectful. Okay. So if there are no doubts, then we can move on to the first spectrum of disorders. So we'll be covering like some major psychotic disorders, right? Uh, yeah. So before we go ahead with this, right, like looking at even looking at like different types of like psychotic disorders and stuff, one thing that like a lot of like people might not be aware, one of psychosis is one of the most popular disorders that we do have, especially in India. Like we know that depression or suicide rates are very high, right? But other than that, psychosis, because there's a lot of stigma when it comes to schizophrenia, right? People are scared of like and when I say people, it's not just the layman, but also like I've seen students who are like the toppers or whatever, or like even working professionals be scared of someone who has schizophrenia, because they have just because they're being ableist basically, right? But you have to understand that there are people who do have like schizophrenia or any other psychotic disorders, right? They are like you and like you and I, they're nothing like different, or they're not monsters, or they are not people who will harm you. There have been cases where, yes, where people have had like command hallucinations, and they have caused harm. But then it's not that every person will do that. It just like if there was more awareness about schizophrenia or mental health in general, then they would have understood and given care. So it's not that we cannot just assume that, okay, this person experiences psychosis, any form of psychosis, this person is a harmful, dangerous person, right? And if you look at the numbers are very high. So a lot of people living among us, living with us, do experience different forms of psychosis. So exactly, exactly. And that, someone with schizophrenia is very violent, but then you have to understand that for the person who might have schizophrenia or, other forms of psychosis, them to live with those conditions, to experience those hallucinations or delusions is very scary, you know. So like it's more scarier for them, you know. So please do look up and about the number of people who do have psychosis, and you'll understand okay, okay, you know. And they can have a job, right? They can complete their studies, they can do amazing work, write amazing novels. I know some people personally as well, and they are really kind, compassionate people, very good with their politics, very understanding of things as well, you know. So we really need to first and foremost get rid of the stigma or the ableist perspective that we will have, right? So they're just like, you know, the diversity model of disability. They're just another human being who has like these experiences. So that is how you should be looking at all disorders, especially psychosis, because the stigma for psychosis is very high, right? So okay, now let's since I said we'll be taking a phenomenological approach, let's take this person. Let's say her name is Meera. Okay. uh Mira had, you know, like uh, so there are differences in gender. Like there's no essay like a thumb rule, but usually men tend to develop like schizophrenia, psychosis earlier, like, you know, usually in their late teenage or early 20s, and relatively women develop it a little later, maybe from their, you know, late 20s or 30s, right? But there's no like I say thumb rule. It can, you know, like differ and depends on people's life experiences and those things. But on an average, you know, that is like the thing. So let's say Meera, okay, she is you know, working her like a corporate job, because that's the mostly like corporate jobs are the norm, right? And then, you know, slowly she will, let's say, you know, like there can be, okay, before that let's just clear the basics. ठीक है. Illusion. What are illusion? Illusion is a misperception of real external stimulus, right? As you can see, like there are like a lot of paintings or artwork which show that there is an illusion. Or like, you know, let's say sometimes in the dark, let's say you've gone to your village and there's no light, or it's dark, and you see, like, you know, you can see a rope, but you might feel, oh, it's a snake, right? Because you're already thinking ki, okay, I'm in this forest area, and you know there is like snakes around and stuff. So even if it's a rope, you might feel ke, oh, that's a snake, but it's just an illusion because there is a stimulus that is there, right? So that is an illusion. A lot of magicians use the power of illusion to do their magic tricks, right? So where there is something really there, a stimulus is there, right? Then we have delusions, where so delusion is a belief, right? A fixed false belief which cannot be, like, you know, corrected, or it cannot be reasoned with logic, right? It is not aligning with culture or education, right? And then we have hallucinations, which is basically false sensory perception experience without real external stimulus. So here there is no stimulus, but you still might experience it in different ways. So you might see something when that is not there. You might hear something which, you know, is not there, right? Or you might, some people feel, you know, there are, let's say, some insects crawling on my skin when there is no insect, right? So yeah. So those are, yes, another way to take a phenomenological approach and understand disorders is looking at, like, you know, interviews. Thank you for sharing. Uh, thank you, Tushar, for mentioning that. So there is a lot of content on YouTube where, you know, they have taken interviews. So usually when I do teach clinical psychology third sem for my students, we watch a lot of interviews of, you know, real life people talking about their experiences. So I think I had discussed, we I might share that playlist also later. So yeah, thank you for sharing, Tushar. Yes. So, you know, hallucinations happen without like an external or like an actual stimuli, that any actual stimuli, right? um one thing which is majorly overlooked, or people hardly talk about it while learning about psychosis. We don't really talk about this, is the cognitive symptoms, right? Even in the DSM, if you look for the criteria, we've not really talked about cognitive symptoms, but when you read up upon people's experiences, when psychosis starts, there's a lot of like cognitive impairment that also happens, right? That doesn't mean that this person becomes dumb or their IQ gets affected. It means that maybe they'll have problems with attention, focusing on things. Maybe their memory will get affected. Brain fog might happen. Might They might face difficulties in understanding social cues that are there, right? So these are like the base, like just the basic understanding. Okay, let's say this person Mira, right, starts having, like, she's going about her day, but then slowly, she starts feeling like, oh, my manager, like my manager or my colleagues, like they are, like, or let's say, like, she starts having certain suspicions. Okay, maybe they have some ulterior motives. She goes home, and when she goes home, she might feel, okay, there is, like, my neighbors, they're looking at me in a certain manner. Why are they looking at me that way? Are they thinking something about me, right? Like, are they planning, are they forming plans with my colleagues, that they are, they are coming for me. There's something, they are going to harm me, right? So that's a delusion. It's a belief that she has, that okay, maybe some people are out there to get me, right? Then okay, also, like, delusions, hallucination, there's no pattern, there's no sequence. And again, like, when you look at like DSM, it doesn't have to be all. It just, like, some, like, basic two or three out of these, right? So, and they can happen together, they can happen separately as well, right? One, like, very common hallucinations that happen for a lot of people are, just seeing shadow figures, for example, right? Where they might see, like, these dark figures, might not see like actual individuals, but can you just, yes, yes, I will cover that. I'll just, like, go with my so, as this is the foundational series, right? We'll just, there will be much more detailed explanations of these each disorders, and we will be covering those as well. Different types of hallucinations. We'll be looking at disorders from Fish's perspectives as well. So we will be doing that, but a little later, right? I'll just try to, like, complete whatever I have, like, planned, and then we will be discussing that though. So yeah, uh, I think I was talking about hallucinations. Yeah. So, and then, yeah, one of the common hallucinations that, people do have, like, visual hallucinations, it can be, shadow figures that they see, or people, like, it doesn't always have to be like from, like, harmful hallucinations. Like, again, when we think of like delusions, or like, when we think of hallucinations, people think, oh, and it is majorly a very scary experience. But a lot of people also have sometimes, like, let's say, one of my clients, he said, okay, sometimes when the hallucinations, like for auditory hallucinations, when they're saying nice things, I feel, and this is a person who does not have like a lot of friends and has working parents, so is usually home alone. So he says, "Ki, I feel very lonely, but then, when I hear the hallucinations, and they are not being mean, but they are just there, saying nice things or neutral things. I feel nice. I feel like someone is there with me, right?" So again, this is something which we don't usually, like, think about. Okay, oh, hallucination sometimes can be a good thing for some people. Of course, like, there are much more, like, deeper discussions into this, but just giving one example, right? Like the experiences of hallucination, right? For some people, sometimes, like, this one another person, right? Let's say a name, like, let's A, right? So A had like very traumatic sexually traumatic experience, and one of the themes of her hallucinations are the, those rapists, those horrible people, right? But then there are times where she has hallucinations of her friends being around as well, which then helps her feel better, right? So when we look at hallucinations, we don't have to think, oh, it is a scary thing. Sometimes it can also help the person feel better in that moment, so that is another way of looking at hallucinations, right? So yeah, then we have disorganized speech. When we understand, look at disorganized speech, is basically, sometimes they might just, in a sentence there can be a lot of like derailment where, they're going off topic, or they are talking but it is not making a lot of sense, right? Incoherent text, like, or speech, or there is word salad where, or they're making up words which do not exist or do not have meaning, right? So disorganized speech, that is what disorganized speech means. Then there we have disorganized behavior. I think one great example of like understanding schizophrenia is the movie Laila Majnu. If you guys have watched it, the way they have shown the progression, I think that is very well like psychologically backed, right? If you see, so the character Majnu, right? He starts, losing, starts going away from reality. And there are times where like he has like one scene, like for example, disorganized behavior example. There's one scene where he comes from a very affluent family. He has all the resources, right? But then he goes to a village and he's using a washroom there, right? He doesn't need to do that, right? But he's doing that, right? So it is like, behavior, disorganized behavior, grossly disorganized behavior, which does not make sense, right? Let's say like right now in May it's usually very hot, but then the person might, wear like a lot of clothing, or they might wear like, a sweater because, they feel it is cold for them, right? So that can be disorganized behavior. Disorganized behavior could also mean, like just not like catatonia, where, they are not moving, they are just in this very, they might like stare at a spot for a really long time, or they might be in a physical position and not moving from that position for a really long time, right? So any behavior which does not like kind of like make sense, like why would they do this, right? Like there's no reasoning for it, that is like disorganized behavior. So when this these behaviors, so this the timeline I've put on the basis of DSM, right? When it is, let's say, these behaviors range from at least 1 day to a month, right? Like let's say this person experienced loss of a loved one, right? And that was a very big shock to them, and that led to this person experiencing psychosis, but it was just for, let's say, 2 weeks, right? And after that, like they were fine, and maybe they seeked help, or they had like their community around, they started medications, right? And they did not have any other symptoms, and it lasted just like, under a month, right? So that then we call it brief psychotic disorder, when these things, when these symptoms plus negative symptoms. So when we look at, so there are like, we will discuss positive and negative symptoms in detail in future, right? But to understand it now, negative, you have to look at like negative and positive symptoms with regards to, like, like how in maths we have addition and, like, subtraction. So like negative is just like minus, subtracting something. Positive is adding. So like, disorganized speech may, if there is like, or like hallucinations will come under positive symptoms. Negative is subtracting. So like, when, let's say, one of the common symptoms is, people having a psychotic, like, or having experiencing any form of psychosis, might talk in a very deadpan manner, where, there is no expression on their face, They're talking in a very monotonous robotic voice. There's no emotions, and they're talking in a very, deadpan manner. So there's subtraction of emotions, right? Or they might not feel motivated to do things that they usually do. Subtraction of, or like negative. So, negative symptoms, that is, those are negative symptoms, right? So here one, like, this is according to DSM again, like negative symptoms. So when that, those, like symptoms, if they are for more than a month but less than 6 months, so like let's say for 4 5 months these symptoms were experienced by Mira, but then, later, like, she got her treatment, and or whatever distressful uh, event was happening in her life, let's say reorientation happened, and right now she's not in that distressful environment, so that itself just helped her. That can also be, sometimes that itself can also be treatment for people, right? Like reorientation. And it just lasted 4 months, 4.5 months. Then we call it schizophreniform disorder. Okay? And when these symptoms are experienced for, more than 6 months, so again, when we say these symptoms, it doesn't have to be every day of that 1 month, every day of those 4 months, every day of like 8 months, they experience these symptoms. It can be like, like alternate days, right? It can be maybe once a week, right? It depends. So when we think, 6 months, it doesn't have to be every day, even for like brief psychotic disorder, right? And it doesn't have to be every symptom will be experienced. Sometimes it can just be delusion where, oh, like this singer, he is writing songs for me, like this person is actually in love with me, and like Justin Bieber, for example, he's writing the love songs for me, so that's a delusion that I have, right? So sometimes it can be delusions, sometimes a person can experience more of hallucinations, right? And it doesn't have to be an everyday experience. It can range from, some people might experience it every day as well, right? Again, so like it's a subjective reality, subjective experience. So like the way schizophrenia is happening for person A versus person B can be very different. So I hope you guys have understood these three things. I would also like to do, like, case studies. So like these are like real life examples. Okay. So person, so like the first patient, like Mr. A, 21 years old. Aggression. So like why I've mentioned aggression. So like a lot of usually a lot of men, like we have seen. So again, it's not in the symptom checklist, right? But a lot of men end up like, for their entire childhood, teenager, they might have been the most quiet, very polite, or like having no aggression issues. But because of schizophrenia, they could develop aggressive tendencies. They might get angry, they might, start a conflict, physical, like depending, again, this is not that because that person is dangerous. It could also be the way, the people around this person is treating them, and they're reacting to it, right? So again, it's not that the psychosis is making that person aggressive. A lot of times, like when care is not provided, when other people are treating you badly, plus on top of that, when you are having these experiences of these symptoms, right? And for this person especially, lived in a very abusive household. So, and they were forcing, there was also some history of sexual trauma as well. So the person was, and then he did also show. So one thing that happens is, especially with people who experience psychosis, is people do not listen to them, right? Which is very, very, very wrong, right? We have to be like, then all the politics about believe the victim, believe them, goes away, because you're like, oh, this person is insane, so that is very wrong. People can be like, oh, this person just might have just hallucinated, and this is not actually happening, so it's very wrong to not consider the person's experiences. Because when we look at it from a treatment perspective, right? When you look at the delusions, when you look at the hallucinations, you have to also understand, a lot of times, like there can be certain types of maybe delusions or hallucinations which it might be difficult to understand the meaning behind them, right? Like shadow figures, which is a very common experience for a lot of people. They might see shadow figures which does not really tell us about, like, what is the uh, where is it coming from, versus the person who experience, seeing their rapist in their hallucination. Then we know, okay, it is the sexual trauma which has resulted into, all of these mental health issues, right? But you should, when you are listening to, when you are doing their case history, when you are taking the case history, when you're talking to, your clients, your patients, you should try to find a trend, or try to find a pattern, try to find the underlining theme. You know how when you do qualitative analysis, right, when you do a qualitative study, you try to find like different, you do coding, you categorize them, you try to find what is, like, the underlying theme, right? Similarly, I would like you to, when you are talking to your patients with, psychosis, try to understand where is that delusion coming from. Like, for example, one of my clients, right, he has a delusion, like persecutory delusion, where he feels ki, like, even his parents, they have ulterior motives and they're going to harm me, right? Or there was some form of, so not even bullying, but he did have some negative childhood experiences where, the children that he used to play with, would always like take advantage of his kindness and things like that. And that really affected him, right? When we look at, like, again, that thing where like parents or even we might feel, okay, oh, it's not a big deal, but then we are no one to decide, okay, what is a big deal for the other person or not, right? And now those things come as in the form of delusion, where, like the person who he's grown up, but he feels ki, those friends, because they're his building friends, so they had some ulterior motives, and my parents might have told them to act in this manner to make me stronger, things like that. So what does this tell me about the person? So when I say ki, you have to look at the underlying meaning or try to find themes in the delusions and hallucinations, it's also to understand the person better, to understand their entire, a whole personality, and not just looking at like, oh, schizophrenia. What this tells me about the person is, okay, there's a lot of like, like the feeling that, oh, I am not good enough. It's like, oh, because this person, like my parents might have told them, or my parents might have told my tuition teacher to be more harsh on me so that I will, improve in my studies. So this person sees, is very competitive, his own definition. So like, I hope you are I'm able to explain, like, why you should look at the theme, because those themes will then tell you more about the person, right? So similarly, like this person, this patient of mine, every day he would, so every day, so this was in Thane Mental Hospital, regional hospital. Every day he would tell me a different story, right? Like one day he'll tell, oh, I am a, like, so in the case history taking, you have to ask about profession. So one day he'll tell me, I'm a fighter pilot, fighter pilot, fighter jet, like the pilot of a fighter plane, you know. Then the next day he'll told me ki, oh, Indira Gandhi is my mother, and she built that, new road from the airport, and it was built for me, you know. So again, every day he's telling me a different story, but then there's still something that I can figure out from this, right? He had then eventually looking at, like, sitting with all the different stories that he has told me, right? I found a theme which was like, and again, his hallucinations, it is eight, but I'll take, like, some few more minutes, just, we'll discuss these cases. I hope that is okay. His hallucinations me, he would see like Amitabh Bachchan as, and he would say, okay, that is my father. Amitabh Bachchan is my father. And he would see Amitabh Bachchan there, you know. And then when you go to find out, he did, as I mentioned, like, he did live in an abusive household. He did show me, burn, like scars on his knees, where, like someone had like, like you like a lot of parents do that, where they'll take a kitchen utensil and they'll put it on the gas, and then put like just put that on your hand or something, so that, so and the father had hit him as well, and then he had reacted to it, and then in the file, or he was seen as, oh, this person is aggressive. But then, is this person aggressive, or you're treating him, or you're pushing him to a point where he will react in a certain manner, right? So yeah, so his themes, when then you understand, okay, the delusions, like, like, oh, Indira Gandhi is my mother, like, Amitabh Bachchan is my father, and he's standing there, like looking at me, so like looking, like in a looking out for me, being protective. So then what this tells me about the person, like these themes of hallucinations and delusions, a lot of parental issue, like lack of safety from parents, right? Looking for, maybe, there can be a possibility of a lot of neglect as well, parents not giving the attention and love that the child deserves. So that's why, like, oh, Indira Gandhi is my mother, and she built that airport road just for me, right? So this is how I want you guys to, try to understand, like, these are the delusions and hallucinations. What are they, what could they mean, what are the underlying themes, or, and like reading between the lines, basically. So like take a qualitative research analysis approach towards it, so that. Then there is Mrs. H. So this is an interesting perspective that we learned. So this was one of my students on their internship. So their patient, she is a Muslim woman, and she had, like, schizophrenia history of. And by the way, like, when we do discuss these disorders in detail, I'll be able to speak about this more. But a lot of, like, this is like the experience, like my own experience when I was doing my internship, my students experiences, like a lot of women, not just like, here I'm mentioning like her religious identity, but that does not mean it's just like, Muslim household. For domestic violence, like, there is no specific group, it is equally high in throughout all communities, like religion, caste, class. So it's equally high everywhere. Here I mentioned it because she was a Muslim woman who had, experienced a lot of domestic abuse, and which is again, like, her husband had hit her on the head, and which then led to her developing schizophrenia, right? So in her hallucinations, she would see Ma Durga, right? Goddess Durga. I hope everyone knows. So like, what is the story of Durga, right? Like, goddess, we have different goddesses. We have goddess Saraswati, Lakshmi, but Durga specifically, as we know, she's someone who stands up for herself, who will fight the fierce goddess, right? So very interesting, which showed, then what does this tell me about this person? Can you guys quickly tell me? A woman who has a history of, sexual, yeah. So that, like, it could be again, seeking justice, yes, wanting to stand up for herself, or maybe Durga Ma standing up for her, yes, yes, correct, correct. So also, like, this is again very important, because when you are a clinical psychology student or a psychologist, you have to do case conceptualization. I think most of the colleges do that, right? So you have to look at the, yeah, schizophrenia is genetic, but it can also be organic sometimes. Organic, which means ki when genetics is not the reason, or like, organic means like because of this physical injury, it has caused a disorder that is organic. Schizophrenia can be caused because of trauma as well, so it is not necessarily always genetic. So yeah, when you do case conceptualization, you're looking at the person entirely, right? So this is something you can mention, okay, what do I understand about this person's, deep desires, or their aspirations, or the wounds that they have, which they might not tell you directly, but maybe through their delusions and hallucinations, you get an understanding of it, right? Then this Miss K. So this is very important case, right? So this woman, she was experiencing, so her, she was her hallucinations and delusions ka theme was sexual trauma and rape. And when taking case history, she mentioned ke, oh, gang rape happened. And so there was like two instances of gang rape and then individual rape and things like that. And then what most professionals look at, oh, this person is schizophrenic, this person is psychotic, like what if she is just lying, which is very, very wrong, especially in such a sensitive matter, right? Like most, if not all, right? Like apart from like, other disorders, like other types of hallucinations, right? Like the shadow figures or certain like random noises which might not mean anything, incoherent sounds or sentences, right? We cannot try to understand the meaning behind those, but then there are other experiences which are relevant to trauma, right? Like the first patient that I talked about, he saw Amitabh Bachchan as his father. He thought Indira Gandhi was his mother, right? So, like, what is this mother father only, right? So, that tells me that he has like childhood trauma, parental wounds, right? So usually like hallucinations and delusions, so they are also a way to cope, right? Like a lot of times we might daydream, for example, like, oh, you have a crush and then you daydream about like a domestic life with them, right? Like right now that's not a possibility, but it makes us feel nice. Let's say heartbreak happens, and then I still daydream about how, oh, what if, or like how it could have been, right? It helps us cope in a certain manner. Similarly, if we look at this is another perspective of looking at like psychosis. What if our brain is just trying to cope with something which we were not given, right? So when I feel ki, oh, my father is Amitabh Bachchan, someone very prominent, and someone who is always there, he's always there looking at me, trying to see if I'm all right or not. My mother is Indira Gandhi, she's doing these things for me. It shows that I did not get this from my parents, but now through hallucinations, this is happening. So schizophrenia, it can also be, these delusions, these hallucinations can also be a way of trying to cope with traumatic incidences or experiences of our life. So that's also one perspective that you should take into consideration. So when this woman ka thing happened, right? So this was actually my classmates. When I was doing my internship, my classmates' patient, and when we went and told this about, you do a you tell your professor, and my professors, and even some people at the hospital, they, like, would not taking it seriously, right? And they're like very, the first thing, just very quickly dismissing, ke, oh, but she has schizophrenia. What if she's just, like making things up? It's not, does not have to be ke, or she has gone through. But then, like, why would this person hallucinate about something so violent and so disturbing? If they, there has to be some connection to it, right? You cannot outright dismiss it, right? So that's why the earlier explanation also, what I was saying, ki majority of times the delusions or hallucinations are a direct result of the trauma that you've experienced, or it can be a way of coping with something that have not received, or coping with a traumatic event, right? So so my professor very sadly, was very quick to dismiss, oh, it's like this might not be the case, and this person has schizophrenia, so we cannot believe it. But then later, what happened was we checked the file, and the file had like a pregnancy test. So in that hospital, whenever there was like a sign or like a possibility of sexual trauma, they would do like pregnancy test and stuff. So that was not there in every woman's file, only for the women or men who might have experienced sexual trauma. Like, of course, men ke liye, not the pregnancy kit, but just saying, okay, so that was there. And then we reported back, and then of course my professor was like, oh great, which was again not the best reply, because ऐसे नहीं होता. But it's very sad that you had to go and check the file to make sure कि why can't just we believe, and also why can't we have the understanding कि this person is having these kinds of delusions or hallucinations. Maybe something might have happened with regard on those lines as well, right? So very, very important to Ha, yes, yes. Again, Kushi, since this is like the foundational level, I cannot like go and I do not have the time to go do a deep dive. But when we do, that's all right. That's all right. That's a very good question. But when we do learn about these disorders in detail, I will tell you, like, I will, like, walk you through how we can deal with these cases. And just to end, yeah. So again, for psychosis, for schizophrenia, or like the assessment that you usually do, right? Rorschach ink block test is a very good one, but the a lot of, I think, most colleges right now very sadly are focusing on the Clover method of analysis, which does not really give you like a very good picture. If you can learn the Exner method, that would be great, because it gives like a very in-depth understanding of the person, not just like the conditions, but a lot of different factors that we assess. So like Rorschach, ROR, Rorschach and block test is a good one of the good ways. And of course, throughout, like when you do the clinical interview, that is also an assessment. And then there are certain scales which which have like a checklist of positive symptoms and negative symptoms, right? That is like the assessment part. And for treatment wise, of course, for psychosis, the major treatment is medication, and therapy can come in a little later for support. Like therapy can't be the answer or the main this, but if let's say with schizophrenia there are other things that they might be experiencing, therapy can be used for that. But first, medication is the most, like the go-to treatment for schizophrenia or like other psychosis. Yeah, there is of course like a detailed explanation of this as well, but as I said, okay, once we go, like a little later in the when I talk about this in detail, we'll cover that as well. So yeah. Yes, exactly. Exner is more standardized than Clover, and Clover hardly gives you anything. It's just like reality testing, like so. And it's just like, I think it's just because hospitals may in OPDs you don't have a lot of times there, right? So it's a quicker way to just do like a quick, reality testing. Okay, is it there or not? So that's why Clover has been very popular. But if possible, you should do, Exner method. Yes. Any doubts, guys? I hope I was able to connect everything and explain. If there are any doubts, you can uh type them. And yeah, I hope this method of teaching also works, because we are not going to do like the symptom checklist thing. Like that's not a very great way of learning, and we're looking at human beings. So yeah. Okay, guys. Thank you for the hearts. Makes me feel nice. All right. So I guess there are no doubts. I will see you guys soon. And thank you for listening and being here. I will see you soon. I am ending the call now. Oh, wait. I can end the call, right, Sanjana? Okay. 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 Cool.